Good morning to all. Pascal's principle is defined as pressure exerted on a fluid in an enclosed container is transmitted equally and undimensioned to all parts of the container and acts at right angle to the enclosing walls. This principle says that when a closed container, if the fluid is in a closed container, if pressure exerted in any part of the container, it will spread that pressure to equally to all parts of the walls of the container. So this principle is used when a baby is in uterus. Baby is in baby's intrauterine life. It is live in a fluid. So when baby is in a fluid, if it is adequate, any pressure in the uterus or in the abdomen, it will be equally transmitted to the all parts of the uterus. That's why baby is safe when the fluid is normal and baby is in adequate fluid. Sometimes there may be some variations occur in the fluids that causes some problems in the baby and the delivery. We can see that one in this class. Okay, first problem is polyhydramnios. Polyhydramnios is defined as when the amniotic fluid or anatomically polyhydramnios is defined as a state where liquid amine exceeds more than 2000 ml or AFI amniotic fluid index. We already studied in previous class. AFI is more than 25 centimeter or a single vertical pocket is more than 8 centimeter. We already studied in the USC in previous class that when we are measuring the AFI, we have to divide the uterus into 4 pockets and each pocket's measurement should be taken. So in a single vertical pocket, if the fluid level is more than 38 centimeter or 4 quadrant is totally, when we measure, it is more than 25 centimeter. It is known as polyhydral. So what is the normal amniotic fluid index? So that is 5 to 25 is a normal amniotic fluid. So what is a normal amniotic fluid in the uterus in the intrauterine period? So it should be 800 up to 1000 at the 36 weeks, and it will diminish later on to the 40 weeks. That is normally it will be 800 ml. So if it is exceeds more than 2000 ml, it is known as polyhydramnios. Next we can see the etiology. First is fetal anomalies. Fetal anomalies, that is congenital fetal malformation, that is structural or chromosomal, are associated with polyhydramnios. If any congenital fetal malformation is there, that may causes the polyhydramnios, such as anencephaly, okay, that is transudation from the exposed meninges, absence of fetal swallowing reflex, because this fluid usually some amount is swallowed by the baby. So baby, if the baby having the this anencephaly, so that because of that big baby is not swallowing, the baby will not have the swallowing reflex. And next, possible suppression of fetal antidiuretic hormone. So in this condition, baby may have the suppression of antidiuretic hormone. So that's why baby is more having more urine is passed. Okay, so that's a fluid is excess urine, excessive urination causes. So the because of the anencephaly, all these problems happen and more fluid will be there. Next is open spina bifida, increased transudation from the meninges. That's if the spina bifida is open, there may be increased transudation came from the meninges, that causes the excess fluid accumulation. Then esophageal and duodenal atresia. This also preventing swallowing of the liquid amni by the baby. And facial clefts and neck masses, that is cleft lip, okay, by interfering normal swallowing. So if there is cleft lip, baby will not swallow properly the fluid. Then hydrops fetalis due to ratius isoimmunization. Hydrops fetalis due to the ratius isoimmunization and cardiothoracic anomalies and fetal cirrhosis are often associated with. That also may lead to hydramnios. Then the aneuploidy. This is the uh, chromosomal abnormality. So it's the excess chromosomal anomaly. Okay. So these are the fetal anomalies. You can see from this picture. Okay. This is the anencephaly. This is esophageal atresia, spina bifida, cleft lip or palate, and hydrocephalus. And you can see one missing. Here is one missing can be seen. Okay. That is aneuploidy. Next, we can see the because of placenta. There is we are seeing the etiology due to placenta, that is chorioangioma of the placenta. That is a tumor growing from the single villus consisting of a hyperplasia of blood vessel and connective tissue, resulting in increased transudation. So you can see this is the chorioangioma of the placenta. Third cause is multiple pregnancy. You can see from these pictures, if there is multiple pregnancies in about 10 times more common than its overall incidence. So hydramnios is more common in monozygotic twins. Monozygotic means they each one having separate chamber, usually affecting the second sac. There may be, you can see this is second sac, so there may be more fluid. That is a multiple pregnancy also causes the polyhydramnios. Next, maternal causes, that is diabetics. It is more common in hydramnios. We can see if the we already study the diabetic mellitus condition in pregnancy, GDM in pregnancy. So if the woman is having GDM, there is more chances of polyhydramnios. Associated with diabetic is about 30% cases. However, with adequate supervision and incidence of hydramnios can be lowered. So if the diabetes is properly controlled, we can control the hydramnios. Okay, so it is assumed that the raised maternal blood sugar, when the mother's blood sugar is raised, there is a raised fetal blood sugar will be there. So fetal may be having diuresis, so baby may pass more amount of urine, and that's why there is a hydramnios. There is a diabetic causes hydramnios. Then cardiac or renal disease. This may lead to edema of the placenta, leading to increased standard. We already studied the cardiac condition. So any renal or cardiac diseases in the it may be lead to the edema of the placenta, and that may increase the transudation and polyhydramnios. Then idiopathic causes also will be. So these are the etiological factors of polyhydramnios. Next, we can see the clinical types. Chronic and acute. There are two types are there. Chronic is, it is onset is insidious and taking few weeks. So it will take few weeks, some time for the excessive amount of fluids. It is not happen suddenly. Okay, that is chronic type. Acute is a very rare type. We can see the acute polyhydramnios. So onset is sudden onset within a few days, or may appear actually on pre-existing chronic variety, and the chronic variety is 10 times commoner than the acute. So this acute type is occur sudden onset of the excessive amount of amniotic fluid. That is two types, that is chronic, that is low onset, but in acute it is sudden onset. So each one we can see in detail. That is, first is chronic polyhydramnios. So symptoms are respiratory. The patient may suffer from dyspnea or even remain in sitting position for easier breathing. So when the uterus is gravid and it is more enlarged, it will compress the sternum, and the respiration is difficult for the mother to be breathe. So that's why respiratory symptoms usually appear. Then palpitation will be the, then because of this excessive gravid uterus, the veins will be compressed in the vulva and the legs. So that's why edema of the legs and varicositis in the legs or vulva and hemorrhoids will be appear. So these are the symptoms. Next we can see the signs. The patient may be is in a dyspneic state in the lying down position, and evidence of preeclampsia can be seen, that is edema, hypertension and proteinuria may be present. Next is the physical examination, that is abdominal examination. So abdominal examination, first is inspection. Abdomen will be markedly enlarged and looks globular and fullness at the flanks. We can, flanks means both side. Okay, so both side will be full. Okay, that is markedly enlarged, more than the expected date of gestation. It will be enlarged. Then skin, because of this enlargement, the skin will be tense, tight and shiny with large striae can be seen. Then palpation. Height of the uterus is more than the period of amenorrhea, and girth of the abdomen is round. Umbilicus more than the mono. So umbilicus is we can see the fully filled umbilicus. It is like a flat umbilicus we can see. Then so height of the uterus is more than the period of amenorrhea. Abdominal girth also round, and umbilicus is more than the normal, and fluid thrill can be elicited in all direction over the uterus. So fluid thrill means when we tap to one side, all side we can see thrill, that moving. We are already discussed in the I already told the Pascal's law, the same law, there is a fluid thrill. And fetal parts cannot be well defined. So also the presentation or the position. External ballotment can be elicited more easily. Okay, so that is the, we cannot, because of more amount of fluid, we cannot palpate really the baby's fetal parts, and also we cannot understand the presentation and the position. So this is the, you can see this is abdominal. This is like shiny, more striae, more wide striae can be seen, and abdominal girth also will be more. Next is the auscultation. The fetal heart sound is not heard distinctly. So we cannot hear the fetal heart sound very nearly. We can see like from the very far what we are hearing now. Like that we can hear the fetal heart sound. Although its presence can be picked up by Doppler ultrasound. We cannot hear the fetal heart sound by the stethoscope. We cannot clearly hear the by the fetoscope, but we can pick it up by the Doppler ultrasound. Next is the internal exam. The cervix is pulled up and may be partially taken up or at times dilated to admit a fingertip, through which dense bulging membrane can be felt. So like this condition, cervix will be dilated with the one finger tip can be admit, and we can see the bulged membrane through the cervix. Next is the investigation. So through the sonography, we already told we will do this ultrasonography in the first trimester, and usually done the last. If no problem for the baby or the mother, usually 2 times scanning is enough. So at the later weeks when we do, usually the amniotic fluid must be at the 36 weeks. It should be reached at 1000 ml, and after 36 weeks it will be diminished and should reach to 800 ml. So, sonography. Why we are doing the sonography? To detect abnormally large echo-free spaces between the fetus and the uterine wall. And largest vertical pocket is more. We already explained this in first class. So that is a pocket is more than 8 centimeter. Then AFI is more than 25 centimeter. Do not forget what is a normal AFI. That is the 5 to 25 centimeter. See, if it is more than 25, is known as polyhydramnios. Okay, then the normal amniotic fluid is 800 to 1000 ml. Then second purpose of sonography to exclude multiple fetus, twins and all. We have to find out that. Then to note the lie and presentation of the fetus. Then to diagnose any fetal congenital malformation. We already told if there is any congenital malformation, because of that there is a chance of polyhydramnios. So we have to exclude that we have to find out that any congenital malformation. Next is the blood investigation. ABO and RH grouping, that is RH isoimmunization, may cause hydrops fetalis and fetal ascites. So that may lead to the polyhydramnios. So we have to check out the ABO and RH grouping. And postprandial sugar and if necessary glucose tolerance test should be done. Postprandial sugar should be checked to detect any diabetic. Next is amniotic fluid. So amniotic fluid estimation of alpha fetoprotein, which is markedly elevated in the presence of fetus with the open neural tubes. That's why we can check the estimation of alpha fetoprotein from the amniotic fluid. Next is a different. Sometimes we will be confused. That's a different diagnosis. Sometimes because of twins, the abdomen will be enlarged, and pregnancy with a huge ovarian cyst also misunderstand that this polyhydramnios maternal ascites also may occur. So these can be sometimes we misunderstand that this is polyhydramnios. This is the complication, maternal and the fetal complication. So maternal complication during pregnancy, there is a chance of preeclampsia, malpresentation, then persistence of floating head because of more amount of fluid, baby will not be fixed to one position. It may be changed to different position, and premature rupture of the membrane. Okay, because of premature rupture of membrane, because this more amount of fluid, because of the gravitational force, it may be rupture. And premature preterm labor, either spontaneous or induced labor can be occur. Spontaneous rupture of membrane, because of spontaneous rupture of membrane, there may be chance of preterm labor. Then accidental hemorrhage due to the decrease in the surface area of the emptying uterus beneath the placenta following sudden escape of liquid amni, that is accidental hemorrhage. These are the maternal preeclampsia, malpresentation, premature rupture of membrane, preterm labor, accidental hemorrhage. Next is the during labor, that is early rupture of membrane. Already told, because of the more amount of fluid, there is a chance of during when starting the contraction, there is a chance of early rupture of membrane. Then when the amount of fluid is more, okay, so the head will not be fixed. So that's why there is a space in between the presenting part and the pelvis. So through that space, after the rupture of membrane, when the gush of fluid comes out, the cord may be prolapsed. Then uterine inertia. Uterine inertia means the uterus will be lax type. So there will not be proper uterine contraction. Okay. Then increase operative delivery due to malpresentation. Due to malpresentation, there is a more chance of the operative delivery. Then retained placenta, postpartum hemorrhage and shock, okay, may occur. Then postpartum hemorrhage is due to uterine atony. Okay. Then in the prepurium, there is a subinvolution because of the uterus was very much enlarged. There is a chance of regain the contraction of the muscles, and the involution will not be happen properly. That is a subinvolution. Uterus normal level like churungi varata avastha. Okay. Then increase purpureal more morbidity due to the infection resulting from the increased operating influence. In the preparing there is a chance of more morbidity. Okay, why this morbidity happen? Because of the infection, because of this polyhydramnios, there is a more chance of operative inference and the blood loss that may cause the the morbidity of the mother in the preparium. Next, we can see the fetal component. There is an increased perinatal mortality to the extent about 50% that are mostly due to the prematurity and congenital abnormality. Other contributing factors are polyhydrallis, hydrosfetalis, effects of increased operative delivery and accidental hemorrhage. These are the complications for the baby. Next, we can see the management. The treatment of polyhydramnios is usually uh, tailored according to the underlying causes, because the treatment is different. The treatment is with difference due to the these causes. That is, if it is mild polyhydramnios and severe polyhydramnios. The mild polyhydramnios, it is commonly found in the mid trimester. So mild polyhydramnios, if occur, it usually seen in the mid trimester and usually requires no treatment, because except extra bed test for few days can be provided. Okay, and the excess liquor is expected to be diminished as the when the pregnancy, we already told in the 36 weeks of pregnancy the fluid will be enlarged, but later on it will diminish. That's why we can wait for few days, so the usually the amount will be diminished. But in severe polyhydramnios, in view of the risk involved and the high perinatal mortality rate, the patient should be shifted to the hospital. If the polyhydramnios is severe, we have to shift the patient to the hospital equipped to deal with the high risk patient. So hospital which has the facility for the management of high risk cases, we have to shift the patient to such hospitals. Then we can see the principles of management. To relieve the symptom, to find out the cause, to avoid and to deal with the complication, we have to go for the management. So we have to relieve patient will be, we already explained, patient will be having dyspnea, some difficulties. Okay, so that's and why it is happened, this polyhydramnios, why it is happened, and also to prevent the complication, we have to do the some management. So first, supportive therapy. We can provide the patient the bed rest, because we already explained there is chance of premature rupture of membrane. Okay, so that case we have to give bed rest if necessary with the back rest, because baby mother is having dyspnea, and back rest and treatment of the associated condition like preeclampsia or diabetic as usual line. If the patient is having preeclampsia or diabetic, the same line of management should be given. Indomethacin given orally to the mother, that is 25 mg every 6th hour orally can be given, has been found to decrease the amniotic fluid as it reduces fetal urine output. The baby, because of baby's excessive urine output, we can provide indomethacin, that is 25 mg 6th hour orally. Then we have to go for the investigation, should be done to explore congenital, that is ultrasonography should be done for the congenital malformation with the available gargets, and also to detect such complications like diabetic and RH isoimmunity. We can, if we do the blood investigation, we can find out if the mother is diabetic or RH isoimmunization, blood group problems. Okay, and further management depends on response to treatment, period of gestation, and presence of fetal malformation and associated complaints. So the first line of management is supportive therapy. We have to find out the cause, we have to give them the proper rest, and we have to do the investigation, and we can start the endometrium. So further management we done for like according to the response of the treatment and period of gestation, presence of if the baby having any fetal malformation and any complication. In uncomplicated case, no demonstrable fetal malformation. If the baby does not have any malformation. First is response to treatment. If the mother is responding to the treatment is good, the pregnancy can be continued, awaiting spontaneous delivery at a time. So if the mother is given the proper rest and the medication is given and diabetes in control, preeclampsia also is in control, then we can wait for the spontaneous delivery and we can go for the tape. Then, if the mother is not responds to the treatment with the maternal distress, then what? Then, if unresponsive, we have to see the weeks of gestation according to that, and we have to go for the management. If the pregnancy is less than 37 weeks, an attempt is made to relieve the distress. So, if the baby is mother is less than 37 weeks, we have to make management for the relief of distress with a hope of continuation of pregnancy by amniocentesis. We can go for do the amniocentesis to relieve the distress of the mother, and slow decompression is done at the rate of about 500. That is, amniocentesis can be done. That should be done by slow reduction. That is by 500 ml per hour, and the amount of fluid to be removed should be sufficient enough to relieve the mechanical distress. And ordinarily it should not be exceed 1 to 1.5. If we take out the fluid, it should not be exceed more than 1 to 1.5 liter. And because of slow decompression, chance of accidental hemorrhage is less. So, if we done the amniocentesis, if it is done in very slow process, there is a less chance of accidental hemorrhage. And but liquor amni may again accumulate. That is, if the baby's urine output is more, or any because of any cleft lip, so again the fluid will be accumulate, okay, for which the procedure may have to be repeated. Amniotic fluid can be tested and fetal lung maturity should be made. So this is if the mother is less than 35%. But in our country, usually nowadays it is till 38 weeks we will do the induction of labor. But in foreign countries, they will wait for the 40 till 42 weeks. They tells us until 42 weeks they will wait for the normal spontaneous labor pain to start. So such that condition, all this management should be must. Okay. In our country, if the mother is 37 weeks and is severe excessive fluid, we'll go for the induction and reduction of fluid. Okay. So next, the pregnancy it is more than 36. So it is stable. We will think in our country as after 37 to 40 weeks, it is in term no problem if the baby is out. Okay, because lung maturity will be the induction of labor is done and amniocentesis can be. So that is the ARM should be done, and drainage of good amount of liquor to check the favorable lie and presentation of the fetus. A stabilizing oxytocin is started. So after ARM only we will start the oxytocin infusion. Then low rupture of membrane is done when the lie becomes stable. So after the lie is stable and the fluid is diminished, then only we can do the low rupture of membrane. When the lie becomes stable and the presenting part gets fixed in the pelvis, this will minimize sudden decompression and separation of plasma. If the sudden decompression and sudden escape of fluid happen, there is a chance of separation of placenta. So that's why we have to do the slow removal of fluid. Okay, and change in the lie of the fetus and the cord prolapse can be prevented. Okay, when congenital fetal abnormality, with congenital fetal abnormality, termination of pregnancy is done irrespective of the duration. If the baby have the congenital abnormality and mother is having the polyhydramnios, they will not think for the gestation week, they will go for the termination of pregnancy. So if the mother is more than 37 weeks, അപ്പോൾ ഇതിൽ പറയുന്നത് ഇത്ര നിങ്ങളോട് നിങ്ങളോട് ഞാൻ മുമ്പേ പറഞ്ഞിട്ടുണ്ടെന്ന് തോന്നുന്നു. നമ്മൾ പോസ്റ്റിങ്ങിന് പോകുന്ന സമയത്ത് ഉണ്ടായ ഒരു ഇൻസിഡൻ്റ് ആണ്. പോളിഹൈഡ്രാമിനേസ് ആണ്, സിവിയർ പോളിഹൈഡ്രാമിനേസ് ആണ്. വിഷ് ഈസ് ഓൾസോ ഡയബറ്റിക് ആണ്, ഹൈപ്പർ ടെൻഷൻ ആയിരുന്നു. പക്ഷേ അവർക്ക് ഇൻഡക്ഷൻ ഓഫ് ലേബർ നമ്മൾ ചെയ്തു. ഇൻഡക്ഷൻ ഓഫ് ലേബർ സ്റ്റാർട്ട് ചെയ്തതെന്ന് വെച്ചാൽ അവർക്ക് ഡോക്ടർ പിറ്റോസിൻ സ്റ്റാർട്ട് ചെയ്ത് പേഷ്യൻ്റ് കൺട്രാക്ഷനൊക്കെ വന്നുകൊണ്ടിരുന്നു. ഡോക്ടർ പതുക്കനെയാണ് ഏറം ചെയ്ത്. പക്ഷേ ഏറം ചെയ്തപ്പോൾ എന്നെ സംഭവിച്ചതെന്ന് വെച്ചാൽ ഏറം ചെയ്തപ്പോഴേക്കും ഒത്തിരി ഫ്ലൂയിഡ് കാരണം ഡോക്ടർ സപ്പോർട്ട് ചെയ്ത് പതുക്കെ ചെയ്തിരുന്നത്. പക്ഷേ പെട്ടെന്ന് ഗഷ് ഓഫ് ഫ്ലൂയിഡ് ഇങ്ങനെ വന്നിട്ട് കോഡ് ഇങ്ങനെ പുറത്തേക്ക് ചാടി വന്നു. സോ പെട്ടെന്ന് കോഡ് പുറത്തേക്ക് വരുമ്പോൾ നമുക്ക് കുഞ്ഞിൻ്റെ ഹാർട്ട് റേറ്റിൽ വേരിയേഷൻ വരാം. അപ്പോൾ അതുകൊണ്ട് തന്നെ വേഗം അവിടെ ഡോക്ടർ ആ വജൈനയിൽ തന്നെ കൈ വെച്ചിട്ടിരുന്നു. കാരണം ആ കോഡിന് പ്രസൻറ്റിങ് പാർട്ട് വന്ന് കോഡിലേക്ക് കംപ്രഷൻ വരാൻ പാടില്ല. കാരണം ഫ്ലൂയിഡ് പെട്ടെന്ന് ഇറങ്ങി പോകുമ്പോൾ ആ പ്രസൻറ്റിങ് പാർട്ട് പിന്നെ ആ കോഡ് പുറത്തേക്ക് നിൽക്കും, അവിടേക്ക് കംപ്രഷൻ വരുമല്ലോ. അത് വരാതിരിക്കാൻ ഡോക്ടർ അങ്ങനെ സപ്പോർട്ട് ചെയ്ത് വെച്ചു. അങ്ങനെ ഞങ്ങൾ പേഷ്യനെ മാറ്റി പെട്ടെന്ന് തന്നെ എല്ലാം ചെയ്ത് ട്രോളിൽ തന്നെ ഇട്ട് വേഗം ട്രിപ്പൊക്കെ സ്റ്റാർട്ട് എല്ലാം ചെയ്ത് പേഷ്യനെ തിയേറ്ററിൽ കൊണ്ടുപോയി. ഡോക്ടർ ഡ്രസ്സ് മാറാൻ തന്നെ ആ സമയം മാത്രം പെട്ടെന്ന് ചേഞ്ച് ചെയ്ത് വേഗം നമ്മൾ ഓപ്പറേഷൻ ചെയ്ത് കുഞ്ഞിനെ പുറത്തെടുത്തു. So that is the problem will occur in the polyhydramnios. അപ്പോൾ ഇതിനൊരു പറയുന്നത് ആദ്യം ഫസ്റ്റ് അമ്നിയോസിന്തസിസ് ചെയ്യുക. ദെൻ അപ്പോൾ കുറച്ച് എമൗണ്ട് ഓഫ് ഫ്ലൂയിഡ്സ് എസ്കേപ്പ് ചെയ്യും. ദെൻ നമ്മൾ നോക്കുക ബേബി കുറച്ച് ഫ്ലൂയിഡ് പോയിക്കുമ്പോൾ ബേബി വന്നിട്ട് ഇങ്ങനെ ഹെഡ് ഇറങ്ങി ഇരിക്കുന്നുണ്ടോ എന്ന് നോക്കുക. എന്നിട്ട് നമ്മൾ ഓക്സിറ്റോസിൻ ഇൻഫ്യൂഷൻ സ്റ്റാർട്ട് ചെയ്യും. ദെൻ നമ്മൾ ഓക്സിറ്റോസിൻ സ്റ്റാർട്ട് ചെയ്ത് ഒരു നല്ല കൺട്രാക്ഷൻ ചെയ്യുമ്പോൾ ലോ റപ്ചർ ഓഫ് മെംബ്രെയിൻ ചെയ്യാം. ഓക്കെ, ലോ റപ്ചർ ഓഫ് മെംബ്രെയിൻ ചെയ്യാന്ന് പറയുമ്പോൾ നമ്മൾ ചെയ്യുമ്പോൾ ഇതുപോലെ കൺട്രോൾഡ് ആയിട്ട് ചെയ്യാൻ പാടുള്ളൂ. അല്ലെങ്കിൽ പെട്ടെന്ന് ഡീകംപ്രഷൻ വരുമ്പോൾ there is a chance of cord prolapse and the plasmal separation. Okay, so this is about if the mother is more than 37 weeks. Next is the duration of labor. Usual management is followed as outlined in the twins pregnancy. നമ്മൾ ലേബർ എങ്ങനെയാണ് പോകുന്നത്, ഇന്റർണൽ എക്സാം ഷുഡ് ബി ഡൺ സൂൺ ആഫ്റ്റർ. നമ്മൾ പറഞ്ഞത് തന്നെയാണ്. നമ്മൾ ഇപ്പോൾ ഏറം ചെയ്ത് കഴിയുമ്പോൾ ഇന്റർണൽ എക്സാമിനേഷൻ ചെയ്യണം. നമ്മൾ എന്തെങ്കിലും കോഡ് പ്രൊലാപ്സിൽ ഒന്ന് എക്സ്ക്ലൂഡ് ചെയ്യണം. ഇഫ് ദ യൂട്രിൻ കൺട്രാക്ഷൻ മേ sluggish and oxygen infusion may be started. After the ARM infusion, after the ARM, we have to check for the uterine contraction. So the uterine contraction is not enough, or it is not enough contraction, we can start the oxytocin infusion. Okay, to prevent postpartum hemorrhage, we can have intravenous method 0.2 mg should be given after the delivery. This is usually we given after the delivery of the anterior shoulder. It is a normal procedure. After delivery of the anterior shoulder of the baby, we will usually given the method in 0.2 mg. But in this condition, we should not forget just to prevent the postpartum hemorrhage. Okay. Then one must remain vigilant following the birth of the baby, following the retained placenta, and postpartum hemorrhage and shock may be there. So we have to be vigilant about the retained placenta. Okay, so that's why we should check for any retention of placenta, and baby should be thoroughly examined for any, because of this polyhydramnios there is a chance of any congenital abnormality. So baby should be examined for any congenital malformation. This is a scheme of management. Till now we discussed about the management. So just for if the patient is with the chronic polyhydramnios, we can do the hospitalization, and we have to check for the blood investigation, the post PP, BS and the ABO, RH grouping. We can do the ultrasonography. After that, if no fetal abnormality and the woman is response to the treatment, can continue the pregnancy. Management of the only complication factors, if any, should be done. And maternal, if there is maternal distress, if no fetal abnormality but there is maternal distress is present, if the less than 37 weeks, amnio reduction and repeated till fetal maturity. Okay. And if the pregnancy is more than 37, that is 38 week plus, amnio reduction and correction of the lie is needed, then stabilized by the oxytocin drip, then IRM, that is controlled. And if fetal abnormality is the delivery irrespective of gestation, and cervical ripening, and ARM is the method of delivery is done. This is a scheme of managing. You are clear about this management. Next we can see the next condition of hydramnios, that is acute polyhydramnios. നമ്മൾ കണ്ടു chronic polyhydral. Next acute polyhydramnios is extremely rare. The onset is acute and the fluid accumulates within a few days. So it is usually occurs before 20th weeks. Okay, നമ്മൾ chronic എന്ന് പറയുമ്പോൾ after 20th week ലാണ്. It is before 20th week. It is usually associated with monozygotic twins and twin-to-twin transfusion syndrome from one twin to other twin. ഒരു ട്വിന്നിൽ നിന്ന് മറ്റേ ട്വിന്നിലേക്ക് ട്വിൻ ടു ട്വിൻ ട്രാൻസ്മിഷൻ ഒരു ട്വിൻ പ്രഗ്നൻസിയിൽ ഒരു ബേബിയിൽ നിന്ന് മറ്റേ ബേബിയിലേക്ക് ഒരു വെയിൻ കണക്ഷൻ ഉണ്ടായിട്ട് ഒന്നിൽ നിന്ന് മറ്റേതിലേക്ക് പോകുന്നു. That is the twin to twin transfusion syndrome or chorioangioma of the plasma. Because of these problems, there is a chance of acute polyhydramnios may develop within a few days. Usually occurs after the 20th weeks of pregnancy. Symptoms എന്ന് പറഞ്ഞാൽ features of acute abdomen and predominate such as abdominal pain, same nausea, vomiting will be there. And signs: the patient looks ill and absence of features of shock, edema of the legs or presence of other associated features of preeclampsia. The abdomen is hugely enlarged more than the period of amenorrhea. The wall is tense with the shiny skin. Okay, then a fluid therapy, we already explained this same in the chronic polyhydramnios. Okay, fluid fetal parts cannot be felt nor in the fetal heart sound audible. An internal examination reveals taking up of the cervix or even dilation of the os through which the bulged membranes are felt. And sonography shows multiple features or at times fetal abnormalities also can be seen. These are the signs symptoms of acute polyhydramnios. Treatment is most often spontaneous abortion occurs. In cases with severe twin-to-twin transfusion syndrome, repetitive amnio reduction until the AFI is normal should be done and may improve the perinatal outcome. A late laser ablation may cure the cause of twin-to-twin transfusion syndrome, whereas amnio reduction only treat the symptoms. So laser ablation can be done. Okay. Next is, till now we discussed about the polyhydramnios. If the amount of fluid is less than the normal amount, it is known as oligohydramnios. So oligohydramnios or otherwise it is oligamnios. We can say just oligamnios or oligohydramnios. So definition: it is an extremely rare condition where the liquor amni is deficient in amount to the extent of less than 200. So normal amount പറഞ്ഞു 500 to 1000 ml ആണ്. So if 1500 ml vare normal ആണ്. If less than 200 ml, it is known as oligohydramnios. Okay. So sonography, it is defined. Sonographically parayane, it is the maximum vertical pocket of liquor is less than 2 cm. Okay, or amniotic AFI is less than 5 cm. നമ്മൾ 5 to 25 ആണ് normal AFI എന്ന് പറഞ്ഞാൽ. So AFI less than 5 ആണെങ്കിൽ or 10th percentile കുറവാണെങ്കിൽ, you can see it as it is a oligohydramnios. You can see from this picture there is no fluid. Very little amount of fluid is in this. This is the pockets. Okay, only little amount of fluid. With the AFI less than 8 cm, that is below the 5th percentile, or more than 24 cm, that is above 95th percentile, and was considered abnormal at gestation age. So from 28 to 40th week ingane varuvaanengil, it is less than 8 cm, more than 24 cm varuvaanengil nammal prathekam shraddhikkendu. So we can see the etiology of oligohydramnios. Fetal conditions such as fetal chromosomal or structural abnormalities, renal agencies, obstructed uropathy, spontaneous rupture of membrane, intrauterine infection, drug, that is PG inhibitors or AC inhibitors uses, and post-maturity. Post-maturity is more than 42 weeks of gestation or more, the fluid will be decreased. Intrauterine growth retardation, amnion nodosum, that is a failure of secretion of cells of the amnion covering the placenta. So usually the amniotic fluid is secreted by the different sources, baby's urine from the placenta covering amnion, and we from the different sources it is. So when the secretion of the this amnion that is covering the placenta is decreases or failure occurs, there is amnionodosis. That is the situation also causes the oligohydramnios. And maternal conditions such as hypertensive disorders, uteroplacental insufficiency, dehydration, and idiopathic causes. So these are the causes of or etiological factors of the oligohydramnios. Next is the diagnosis. Uterine size is much smaller than the period of amenorrhea. Less fetal movements will be the uterus is full of fetus. Okay, we can see full fetus in the uterus, like we can palpate easily the parts. Okay, and but offers scanty liquor. Because of this candy liquor, we can feel like full of fetus. Okay, and malpresentation, usually breech presentation is common, and evidence of intrauterine growth restriction of the fetus will be the. And sonography diagnosis is made when largest liquor pool is less than 2 centimeter. If the it occur if the largest vertical pocket, okay, big pocket, we can see that is less than 2 centimeter. Then ultrasound visualization is done following amnio infusion of 300 of warm saline infusion. That is, yeah, ultrasound infusion when we do, we can is done with the help of ultrasonic guidance. We can do the amnio infusion. We can infuse some amount of warm saline solution into the uterus. That is around 300 ml can be infused. And visualization of normal filling and emptying of the fetal bladder can be essentially rules out urinary tract abdomen. If any problems in the urinary tract, the baby will not be pass urine. So it is the amniotic fluid is formed by the fetal urine and the secretion of the placental amnion. So if the baby bladder is have or the emptying urinary problems, baby's urine output will be diminished. That also causes the oligohydramnios. The oligohydramnios with the fetal symmetry growth restriction is associated with the increased chromosomal abnormalities. So these are the diagnosis factors. Okay, you can do by the palpation, inspection, palpation, sonography. Okay, these are the diagnosis factors. Next is the complication. Complication fetus is abortion. There is a more chance of abortion and deformity due to the intra-amniotic adhesions. Because of less fluid in between the space, baby space, there is more chance of adhesions. ഒട്ടിപ്പിടിച്ചു പോവാം, കുട്ടിയുടെ parts തമ്മിൽ ഒട്ടിപ്പിടിച്ചു, or due to compression. The maldeformities include alteration in the shape of the skull, dry neck, club foot, or even amputation of the lump can be seen. And fetal pulmonary hypoplasia, cord compression will be there because when the contraction occur, the cord may be compressed. So it can be it may be affect the fetal blood flow, and high fetal mortality will be there. These are the fetal complication. And maternal complication is prolonged labor due to inertia, measurements in inappropriate uterine contraction, and increased operative interference due to malpresentation. Because if the oligohydramnios, baby will be in the malpresentation, that is a breech presentation. So the some effect may lead to increased maternal. Because of all these effects, it may be there is increased chance of maternal morbidity. Next is the treatment. And presence of congenital malformation need to deliver irrespective of the period of stay. We already told in the polyhydramnios, same as in the oligohydramnios, irrespective of the period of gestation, we have to go for the delivery. Then isolated oligohydramnios in third trimester with a normal fetus may be managed conservatively. Okay, is the oligohydramnios in third, if we find out in third trimester, we can to manage conservative management. And oral administration of water in this amniotic. So because of, we already told the cause, that is dehydration. So if because of dehydration this oligohydramnios occur, we have to increase the fluid intake, increase amniotic fluid volume by the increased intake of water. And in labor, cord compression is more common. So amnio infusion, prophylactic or therapeutic for meconium liquor is found to improve neonatal outcomes. Okay. So in the labor time there is a chance of cord compression. Then amnio infusion can be given to reduce the condition. That's all about the hydramnios in pregnancy. So hydramnios is pregnancy is two types. It's polyhydramnios and oligohydramnios. Polyhydramnios is defined as the when the amniotic fluid is more than 2000 ml or AFI is more than 25 centimeter or the single vertical pocket is more than 8 centimeter. It is acute and the chronic. And chronic is it is a slow progress, but acute is sudden onset. Okay. Then oligohydramnios is if the amount of amniotic fluid is less than 200 ml. And that's all about the hydramnios in pregnancy, polyhydramnios and oligohydramnios. I think all of you have clearly understood this condition.